Morning, everybody. Pleasure to be here. Each year we bestow the Sheldon, Naiman, and Linda Vickars Professorship in Benign and Classical Hematology to a leading clinician scientist who emulates the philosophies of these two hematologists. Sheldon and Linda were a husband-wife team of physicians really who changed the face of hematology in Vancouver, BC, and much of Canada. Shelley came from Toronto. He went to UCLA and then came to Vancouver in the 1960s, I guess, where he really established, he brought up until then, new concepts in terms of coagulation and bleeding disorders, established the first bone marrow transplant unit, became the first division head of hematology as a separate entity, and then established considerable teaching programs at the university. Linda was born and bred in British Columbia, trained here in internal medicine and hematology, and really worked primarily at St. Paul's Hospital, where she established or built the program in bleeding disorders as well as hemoglobinopathies. And those two programs really have flourished since under the guidance of her at that time trainees who are now independent investigators. Both Shelley and Linda were widely recognized as superb clinicians, teachers, and were keen advocates of promoting science. They received, there are many teaching awards in their names, and they were particularly very much involved in the Center for Blood Research. They were in awe of Earl's accomplishments. They just loved to come to this symposium and others set up by the CBR, and as a result left considerable funds for the CBR that are directed towards training programs, as well as to support this symposium, and many of the trainees who are here were funded by their generosity. So it is my pleasure to introduce Dr. Margaret Ragni as this year's recipient of the Sheldon, Naiman, and Linda Vickars Professorship in Benign Classical Hematology. And to be sure, Dr. Ragni entirely fulfills everything that Linda and Shelley held close to their hearts: a passion for teaching, for training, and research and excellence in patient care. Margaret is a professor of medicine and clinical translational science at the University of Pittsburgh, Department of Medicine, and has long been involved in clinical and translational medicine. In a wonderful retrospective that I found on the web, Margaret relates that when she was a girl, several family members died young from blood clots, and her curiosity was piqued. Why? What can we do to stop that? And that really led her into a career in medicine, which she studied at the University of Pittsburgh and then rose up through the ranks. At a time when clinical research wasn't a real science, Margaret became an expert in clinical trials, and she completed several small trials, but faced hurdles in terms of getting people to do statistical analyses of her work. So she pursued then Masters in Public Health at the university. And since that time, she has flourished. She has filled many roles nationally and internationally, driving clinical trials in congenital hemostatic and thrombotic disorders, including prospective epidemiological studies. Indeed, she led one of the very first multi-center NIH-funded investigator-initiated studies in those bleeding disorders. And not surprisingly, she's served on many working groups to promote the needs of these patients. She's a major advocate at all levels for patients with bleeding disorders and thrombotic disorders. She is also a dedicated mentor for future hematologists, and in a feature article in Hematologist in 2007, her advice to trainees was not to believe in the word no. Instead, to persevere toward your goal. She advised, don't focus on perceived inadequacies and insecurities. Everyone has them. I can sort of hear Shelley, and particularly Linda, expressing the same sentiments. So it's my pleasure to introduce Margaret Ragni to give this keynote address. Let's switch this over here.
So I guess I will start. Thank you so much for that wonderful introduction. I am honored to be here, and I think it is absolutely timely and exciting in this 100th anniversary of von Willebrand disease that I can talk with you this morning about novel therapeutics for females with von Willebrand disease. And by the way, they are novel therapeutics for everyone with von Willebrand disease, but women seem to have more needs, and we'll talk about that. Here are my disclosures. So, in this 100th anniversary of the first description by Eric von Willebrand, a biochemist, a Finnish biochemist, who first described the index case of von Willebrand disease in the Åland Islands in 1926. Of course, von Willebrand disease is the most common inherited bleeding disorder. The index case was a female with type 3 von Willebrand disease who exsanguinated after her fourth menstrual cycle, as did other young ladies in her family. So what's the current focus in von Willebrand disease? It is still heavy menstrual bleeding, HMB, postpartum hemorrhage, PPH, as well as iron deficiency. There's a lack of consensus regarding screening and treatment. Diagnosis may be delayed up to 15 years because of underdiagnosis and undertreatment, and few clinical trials exist to guide treatment. Yet we have some exciting novel therapies on the horizon. So the objectives for the talk today are to review what we have known today to randomized controlled trials in females with von Willebrand disease, the VW-MIN and the VWD woman trial, which I've had an opportunity to work with, and to examine what the current ASH, ISTH, WFH, NHF guidelines present to prevent HMB and PPH, and then finally to discuss current and novel therapeutics for females with von Willebrand disease. And let me move that. Yes. So HMB, heavy menstrual bleeding, is common in females with von Willebrand disease. One of the first studies was ours in 1999, in which we had 80% of the ladies we saw with heavy menstrual bleeding. And that is defined by the PBAC score, or pictorial blood assessment chart, which sums the number of pads and tampons and saturation over the cycle of an ordinary menstrual cycle, and results in a PBAC score of greater than 100, which is equivalent to greater than 80 cc's in patients with HMB. And not surprisingly, 60% have iron deficiency, but it is rarely tested. In an Athens study we did with one of my fellows, Cormick, we found that only 3.5% were tested, and these were at hemophilia centers, and over 70% were iron deficient. Our current treatment is concerning. We have agents that are poorly tolerated and ineffective in 30%, and some are limited by IV administration. We'll be talking about those. Thus, the treatment of HMB is inadequate. Let's see, I'm trying to move forward. For some reason, I'm having trouble moving it forward. Okay, good. Postpartum hemorrhage is also common in females with von Willebrand disease. Over 34% have postpartum hemorrhage, which is defined as blood loss at the time in the first 24 hours of delivery of greater than 1,000 cc's. But the problem is, despite the treatment we have, there's 1.4-fold increased postpartum blood loss as compared with controls. And as you can see in the figure I'm showing, 1.4-fold lower VWF levels, whether you're measuring risdipine cofactor, the antigen, or factor VIII, despite treatment. What is wrong here? And not surprisingly, many have iron deficiency, and including in the most recent study we ran, 95% had iron deficiency, and these were women who were followed and given iron during pregnancy. So treatment of PPH is inadequate in von Willebrand disease. So what I'm really saying here is the lack of safe, effective von Willebrand treatment in women is a major public health problem. Few randomized clinical trials are available. Women are excluded from most trials. No international guidelines exist, and the current guidelines we have show that, for example, they're in flux because, for example, women who have what we call low VWF, that is 30 to 50 units per deciliter of von Willebrand factor, despite having normal antigen levels, have bleeding scores by ISTH-BAT that are consistent with true von Willebrand disease. This all results in very complex decision-making, and we clearly need better treatment for von Willebrand disease. So what do we now know? We're going to talk about two clinical trials, the VWD-Min trial and the VWD-Woman trial. So the VWD-Min trial we ran several years ago, an NIH-funded randomized crossover trial to reduce HMB, comparing recombinant von Willebrand factor on day 1 with tranexamic acid days 1 through 5 to reduce heavy menstrual bleeding. And we found that recombinant von Willebrand factor, surprisingly, was inferior to tranexamic acid. There was no thrombosis, no severe adverse events, but despite no differences in quality of life and healthcare utilization, because tranexamic acid is cheaper, it may be more cost-effective than recombinant von Willebrand factor. So what do the guidelines say? Well, there are two about HMB. The panel suggests using, if you do not wish to conceive, either hormonal therapy or tranexamic acid over desmopressin. But if you, in recommendation 6B, wish to conceive, you can consider using tranexamic acid over hormonal therapy or desmopressin. But these are both based on grade 3 level C data. Okay. So let's talk about the VWD-Woman trial, which was based on the Woman trial that looked at tranexamic acid alone in non-von Willebrand disease. So this was a study we ran at our center. Nikki Makin was the primary author of this. We piloted a 4-week randomized controlled trial in females with von Willebrand disease, and we compared recombinant von Willebrand factor with or without tranexamic acid to reduce postpartum hemorrhage, measured by PBAC score and estimated blood loss. And we found that the addition of tranexamic acid to RVWF did not reduce postpartum hemorrhage, although it was well tolerated. There was no thrombosis, no adverse events. But in addition, as I mentioned before, we found 95% of these ladies had iron deficiency despite receiving iron replacement during pregnancy. So what do the guidelines say? There are 4 items regarding postpartum hemorrhage. Number 1, and most important, set up a multidisciplinary team that includes the obstetrician, hematologist, anesthesiologist, and in the center of this team is the patient who is part of the decision-making piece of this. And the pre-pregnancy levels should clearly be obtained. Von Willebrand factor and factor VIII levels should be greater than 0.5 for neuraxial anesthesia and for 6 hours thereafter. Von Willebrand factor should be greater than 0.5 during delivery and for 3 to 5 days thereafter. And C-section should be reserved only for obstetric indications. And finally, that women should be monitored for at least 3 weeks postpartum for postpartum hemorrhage. And if someone has preeclampsia, aspirin is not contraindicated. So that brings us to what we're really wanting to talk about this morning. What are the current therapeutics and what are the novel therapeutics for females with von Willebrand disease? Well, I'm afraid for that, we're really going to need the help of the Three Rivers Coagulation Cascade, which is in Pittsburgh, and for which our medical students and fellows are absolutely expert because they understand that the intrinsic Allegheny River and the extrinsic Monongahela River all meet at the point, which is Pittsburgh, and travel down the combined pathway Ohio River for the sole purpose of forming a thrombin clot, a physiologic clot. And this is triggered by factors 7 and 11, which are, of course, regulated by our Pittsburgh franchise. So there you have it. And we're going to use this to understand what happens in coagulation. So first, we're going to talk about current therapeutics. Here are the agents we're going to briefly review in preparation for talking about the novel therapeutics. So DDAVP releases von Willebrand factor from endothelial stores. It's an ADH analog. It increases von Willebrand factor and factor VIII. It can be given intravenously, subcutaneously, or intranasally, is very effective in types 1 and 2, but it is limited by a short half-life, by fluid retention, and tachyphylaxis, which is the inability to respond after using its stores in 2 to 3 days. Next, we're looking at tranexamic acid. This inhibits fibrinolysis, so it inhibits plasminogen and that plasmin pathway that is important in breaking down fibrin clots for normal hemostasis. This is a synthetic lysine derivative. It inhibits fibrinolysis and can be given intravenously or orally, effective in types 1, 2, or 3 von Willebrand disease, but it is limited by a short half-life, by the requirement for multiple doses and nausea in at least 30%. Combined oral contraceptives increase the factor VIII and VWF levels. These are synthetic steroid hormones combining estrogen and progestin, and given by the PO route. They are effective in types 1, 2, and 3 von Willebrand disease, but they are limited by headache, bloating, and hypertension. Recombinant von Willebrand factor or plasma-derived increase factor VIII and VWF exogenously. These are glycoproteins that increase factor VIII and VWF levels and also bind platelets. They're given by the intravenous route and effective in all types of von Willebrand disease, but they are clearly limited by the invasiveness of an intravenous infusion and the cost. Now, there are a number, here 3, of non-hemostatic approaches. We'll start with the levonorgestrel IUD, sometimes termed the Mirena IUD. This is a synthetic progestogen that releases local progesterone into the uterine cavity and thins the endometrial lining, reducing HMB. It's effective in all types of von Willebrand disease, but it is limited by painful insertion, bleeding at insertion, and it may be expelled. The other non-hemostatic approaches both destroy endometrial tissue that produces these von Willebrand factor. One, the hysterectomy clearly is more permanent, but these are surgical procedures. They can be done in type 1, 2, or 3 von Willebrand disease, but they are clearly limited by postoperative bleeding, and it's really a last-ditch effort after most other things do not work, and clearly in the case of hysterectomy is permanent. So in terms of our current therapeutics, here are what we just talked about. Their structures, and we've made very clear they are poorly tolerated, they may be ineffective, and they may require frequent dosing. We need better treatments. That's why we're talking about novel therapeutics. Now, we have a long list, but this is really exciting science and very exciting medicine for our females with von Willebrand disease. So let's start with emicizumab. You may say, oh, well, for heaven's sakes, isn't that a hemophilia drug? Well, of course it is. It's a factor VIII mimetic. It's a bispecific monoclonal antibody that binds factor IX and factor Xa, and by mimicking factor VIII, improves thrombus formation. It's given by the subcutaneous route, and it is potentially useful in all types of von Willebrand disease, but Yao and Weyand showed in their short case reports that in type 3, this could reduce heavy menstrual bleeding, and in types 2 and 3, this agent reduced hemarthrosis. And there are clearly limitations because the clinical trials were not done. In fact, most of what I'm going to talk about now is preclinical or very early case trials. But this is very exciting because it's a subcutaneous route. Efanesoctocog is our second drug. This is a factor VIII VWF fusion protein. It is decouples factor VIII and VWF, factor VIII being the limiting step here, and it prolongs the factor VIII half-life. It's given intravenously. But type 2N von Willebrand disease is a disorder in which factor VIII is low because the binding is incorrect with von Willebrand factor. And in fact, Rio reported a case of an 80-year-old woman with a factor VIII level of 5% in her 2N von Willebrand disease who was able to sustain a dental extraction with no bleeding. So we need a lot more information, and clinical trials are underway, but a very exciting drug. Rondaraptivon BT200 is a VWF aptamer. Okay, an aptamer is a single-stranded RNA nucleic acid, and in this case, it's blocking the VWF A1 domain where platelets bind. So by this blockage, it delays clearance, it increases VWF levels, and it improves factor VIII, VWF, platelet counts, and multimers. It's given subcutaneously, and it has been shown to be safe and effective in a phase 2 trial of 2B von Willebrand disease, improving von Willebrand factor VIII, and platelets. It's clearly limited because we only have some of these early reports. We need clinical trials to establish safety and efficacy. The next drug we're going to talk about is KB-V13A12, which is a VWF nanobody. So nanobodies are single-domain antibodies, and here there are two single-domain antibodies, one which binds VWF and one which binds albumin. By this double binding, it delays clearance and increases the VWF half-life. This improves factor VIII, VWF, platelets, and multimers. It's given by the subcutaneous route, and McCluskey showed in type 1 humanized VWD mice, it restored multimers and hemostasis. It's potentially effective in types 1, 2, and 3, but clearly we need clinical trials to establish safety and efficacy. VGA-039 is a monoclonal antibody to protein S. So this monoclonal inhibits protein S. So it inhibits what protein S usually does. So protein S inhibits tissue factor pathway inhibitor. It activates protein C. And by doing this inhibition, it improves thrombin generation. It can be given by the intravenous or subcutaneous route. And Leong showed in VWF mice, either by the IV or subcutaneous route, it could improve thrombin generation, and it has the potential for all types of von Willebrand disease. But clearly, it requires clinical trials for safety and efficacy. HMB-001 is a bispecific antibody to factor 7A. So it binds 7A and the TL1 receptor on platelets, and thereby prolongs 7A, and it allows that to accumulate, increases its half-life, and improves hemostasis. It's given by the subcutaneous route, and it was shown by Gandhi in Glanzmann's monkeys by ex vivo studies. There was increased 7A accumulation and improved thrombin generation. So it would have potential for types 1, 2, and 3 von Willebrand disease. It's only in early phase trials, so we need to learn a lot more about this, but exciting, another subcutaneous approach. Now, there's another HMB. This is more recently HMB-002. This is a monovalent antibody to von Willebrand factor. It's really amazing what's going on in this science. So this monovalent antibody binds to the terminal CK0 of von Willebrand factor and thereby prevents its degradation. It improves thrombin generation and prolongs VWF and the factor VIII half-life. It's given subcutaneously, and Hagar showed that in the VWD mouse model, it improved von Willebrand factor VIII, and thrombin generation. So it has potential for all types of von Willebrand disease. Again, that subQ route, which is so much more preferred, and it's clearly requiring longer, larger clinical phase trials to establish safety and efficacy. Next, we're going to talk about platelet nanoparticles, a really up-and-coming interesting area, and these bind von Willebrand factor. These lipid nanoparticles bind VWF and platelets. This alters the A2 domain and blocks atom TS cleavage, so that prolongs the von Willebrand half-life. It's given subcutaneously, and Roulet showed that in VWD mouse, it reduced the tail clip blood loss, and there's potential for it in either 2B or 3 von Willebrand disease. Again, clinical trials are going to be required to establish safety and efficacy. Next is the allele-specific silencing RNA, another very interesting scientific biologic, and here it binds von Willebrand factor. So these small interfering RNAs silence, in this case, allele-specific RNA transcription of mutant von Willebrand factor. So you can imagine this might be very helpful in type 2A or type 2B, where we know mutations exist. It knocks down synthesis of these mutant VWFs. It's given intravenously, and it was shown by de Jong and others in 2A mice that it corrected multimers, collagen binding, and the bleeding time. Now, it has potential then for 2A or 2B von Willebrand disease, and clearly limitations are that we do not have clinical trials yet that establish safety and efficacy. And now we're going to talk about gene therapy. I think this is exciting. We are ready to turn to VWF, where we target the endothelial von Willebrand factor production. So it's your standard AAV gene therapy, just like we use in hemophilia A and B, targeting the vascular endothelial cells and transducing them to synthesize von Willebrand factor. This is an IV route. Of course, one dose should do you if it's effective, and it would potentially be usable in types 1, 2, and 3. Barbone showed in VWD mice that the AAV VWF provided long-term VWF levels. So clearly we need larger clinical trials that will establish safety and efficacy. So here you have it. These are the drugs that are coming along the pike, and the reason why we need to be very importantly involving women in clinical trials and doing clinical trials in von Willebrand factor. And here you have it. There's the current and the novel therapeutics, and I think I'll stop there and entertain any questions you may have. Thank you.
Thanks very much, Margaret. I'm sure we have questions. Oh, there we go, Shannon.
Good morning, Margaret. Can you hear me?
No, I don't think the mic's on.
Yes, now.
There we go.
Thank you for your amazing talk and done in such a timely, quick way. I am a hematologist here, and I got a referral for what looks like a type 3 pregnant von Willebrand's disease patient. She's about 24 weeks. We're going to see her soon. Your presentation got me thinking about planning around delivery, not to mention all of the other issues which we have to catch up on. And in particular, thinking about the woman trial, when you're giving the 80 units per kilo and the tranexamic acid, yet you still have postpartum hemorrhage. Do you have any advice with your experience?
I wish. You know, here's the problem. I'm so I can't hear very well. Maybe I'll turn audio off. The problem is do not understand why bleeding not well controlled by standard therapies. Is it platelets? Is it something else about local milieu and making these factors more effective locally? I don't, and I can't speak because I can't hear from the doctor. But I wish I could tell you, don't know, that maintaining those levels of 50%. Sorry.
Thank you. No, thank you very much. Appreciate your sage advice.
Other questions? Oh, Ed Prysdale.
Thank you for that really wonderful talk. I, on the other hand, unlike my colleague, am not a clinician. So I will ask you, you hinted at it, is genotyping routine, and is that helping to guide which of these pharmaceuticals is being used. For instance, if we knew precisely where the mutations are, HMB-002 would not be used.
Such a good point. I would say is, I'm hearing yes, I can't talk very well. But basically, what we think we could do, for example, for WFs, we could target those and use an siRNA, knock it down, right, deadly. But, you know, this is evolving. I think all ethnicity are genetic are women, and we think that will be an ongoing appropriate approach to decide therapy. Thank you for your question.
Other questions? Anybody? Students? Nope. Oh, hey you. Good.
Margaret, that was very, very useful presentation. And also I have a couple of trainees from Toronto to come here to listen. So that will be your information is very, very useful. So when I'm working in the Dr. Denisa Wagner laboratory, we knock out von Willebrand factor. We found that animals has a relatively able to maintain their hemostatic condition. My question is from your experience, whether we could identify some other compensation mechanism in these animals that could help for the woman to control bleeding disorder.
We do. I mean, that's the essence that we do not stand why they bleed. And that is with no treatment. Oh, well. Thank you.
Okay, if there's no other questions, I'd like to, on behalf of everybody, thank you, Margaret, for joining us.
Thank you.